Hi everyone and welcome. We hope you're enjoying our Closer Than Ever virtual conference so far. Hi, my name is Holly Hood and I'm the Program Service Coordinator here at the Chromosome 18 Registry and Research Society. We're so happy you've joined us today for this session on OCD with Dr. Larson. And just to let you know, today's session is pre-recorded. If you missed the session, don't worry about it. Our sessions will be recorded and you'll be able to access them later. You'll receive more details in an email after the conference is over. Also, just to let you know, we won't be recording the self-advocate or the sibling panels. I have a few quick announcements and housekeeping items before we start the presentation. If you have any questions during the presentation, feel free to type them into the chat box and one of our staff members will get with the presenter after the conference. Also, please remember to mute yourself and turn off your camera during the presentation. We really appreciate it. And don't forget, our silent auction is open. I will go ahead and type that into the chat box as well. Please feel free to take a look on the website, maybe bid on a few items, and get some great items for you and your family. Also, it is not too late to order some Chromosome 18 merchandise. We will pop that link into the chat as well. And feel free to take a look and hopefully you can get some great t-shirts or a bag for you and your family. And I have a very exciting announcement. Tomorrow evening, we have our Starfish Family Fun Night and Table Touring event. If you haven't got a table yet, but you'd like to get one, we will go ahead and put that link into the chat as well. And feel free to sign up your family for a table so your friends can come virtually and visit you and say hi. Before we get started, I did want to share a little bit more about Dr. Larson. So Dr. Catherine Cody Larson is a child and adolescent psychiatrist, and more importantly, Elizabeth Cody's sister. You may have seen them before. After earning her undergraduate degree in communications at Texas State University, she worked as a research assistant at the Chromosome 18 Clinical Research Center in San Antonio. During this time, she conducted research on the relationship between individuals with chromosome 18 syndromes and their siblings. She attended the University of Texas Health Science Center at San Antonio and earned her degree of MD with distinction in research in 2011. She completed her specialty residency training at adult psychiatry at the University of Texas Dell Medical School in Austin and is board certified in general psychiatry by the American Board of Psychiatry and Neurology. She recently completed a fellowship in child and adolescent psychiatry at the University of Texas Dell Medical School in Austin. She was the past sibling coordinator and has been organizing sibling activities and events at our conferences for over 10 years. Thank you, Dr. Larson, for all you've done for us and for sharing this presentation with us. We hope you all enjoy the presentation and enjoy all of the resources. So without further ado, let's get started with the presentation on OCD by Dr. Larson.
Hello, everybody. Welcome. Thank you for joining me today. My name is Catherine Cody Larson, and I'm going to be talking to you about OCD today. I am a psychiatrist. I specialize mostly in children and adolescents, and I do also see some young adults. And I've come a couple years, talked about different psychiatric diagnoses, and several people have asked to hear about obsessive compulsive disorder and had some questions about it. And so that's why we are bringing this talk for you this year so that we can learn a little bit more about OCD. So what is OCD? So obsessive compulsive disorder. So it has two parts. It has obsessions and it has compulsions. Obsessions are the thoughts, so they are separate things. Obsessions are the thoughts, or with kids often we use the term worries, but not just any type of worries. These are worries that are very persistent and that are recurrent. So the same worry or the same obsession becomes something that somebody is constantly thinking about. They are intrusive, they are unwanted. Some anxious feelings, can be adaptive and a normal part of life. Obsessions are very intrusive and very upsetting for the person who's having the obsessions. And they do cause a lot of anxiety and distress. And specifically with obsessive compulsive disorder, the obsessions are things that the individual will attempt to either suppress or ignore, or if they also have compulsions, they would try to neutralize these thoughts. So sometimes they attach themselves to a behavior that is done in an attempt to get rid of the obsessive thought that's causing them anxiety. So compulsions are the repetitive behaviors. So we have the obsessions, which are the thoughts, and the compulsions, which are the behaviors. And a lot of times we use the term rituals, especially when we're working with kids. So these are things that are behaviors which are repetitive. And we say sometimes it can be mental acts because it can be a thought, because sometimes somebody's compulsion can be something like counting, or it can be having to recite some certain phrase or a certain prayer a certain number of times. So it's a thought, but in itself it's a behavior. And so this is a behavior that is specifically done with the intent of trying to neutralize an anxiety. Or preventing some kind of outcome from happening. And it's going to be something that's clearly excessive or that's completely unconnected from what it's supposed to prevent. So, for example, a very common type of OCD is contamination OCD. And so if somebody has both obsessions and compulsions in this type of OCD, they may have an obsession that if I touch this thing, there may be germs on it, I'm going to get it, I'm going to get sick. There might be germs on that, there might be germs on that, and this becomes this obsessive thought that repeats in their head. And to try to get rid of the distress that it causes, they can do something like washing their hands. And so this is an example of something that is a normal behavior, but it's taken to a clearly excessive point. So it's not just hand washing after using the bathroom and hand washing before you eat. It is a 10-minute ritual of washing hands, which happens so often that their hands are red and dry, and sometimes they will have, this long ritual of having to wash each finger in a certain way, and then they rinse their hands, and then often in OCD, it will feel like it's not quite right, or it didn't quite get rid of that anxiety, or somebody walked in and distracted them and they got out of their little ritual and it just didn't quite do it, and so they have to repeat it and do it again. And so that's an example of the compulsion that is a normal behavior but clearly excessive. And sometimes it can even be totally unconnected from what it's supposed to prevent. So for example, I recently had a patient who had a ritual around brushing her teeth in the morning where she had to tap the toothpaste on the side of the sink a couple of times. 3 times, she had a specific number, and then her toothbrush, after brushing, she had to rinse her toothbrush in a certain way and then tap her toothbrush on the counter a certain number of times. And one day she didn't go through the whole ritual, and later that day, she and her family were supposed to be driving a couple hours away to pick up a dog. And this was when this winter storm recently came through Austin. And as they were driving, the road conditions became very unsafe. And she made this connection in her mind that she didn't do that whole ritual, and then this dangerous driving situation happened, and she from now on must always do her ritual just as she had done it before, because she thought that it somehow had caused the unsafe driving conditions. And with OCD, we have a wide range of how much insight a patient has. So they can have very good insight. For example, this patient knew that there was no logical connection. She knew it didn't make sense, but she couldn't stop herself, because when she's about to do her whole brushing teeth ritual, she would start worrying about where they were going to drive that day and how it was going to be unsafe, even though she knew that it wasn't logically connected. Sometimes we can also see people who don't have that insight, and they really don't see that there's no connection between the toothbrushing ritual and the safety of driving conditions. So whether or not somebody has insight really doesn't affect whether or not it's OCD, because you can see a very wide range of how much insight someone has with OCD. So those are our 2 parts, the obsessions and the compulsions. So you can have one or the other or both. You don't need to have both of them for it to be OCD. And these worries and rituals, they have to be time consuming to be considered OCD. Usually we say more than 1 hour per day. or they must cause significant distress and impair functioning. And usually these things go together because they are washing their hands so many times, they are having a certain ritual around many of their hygiene. So if somebody has a contamination fear, it can be hand washing, and then it also might be around going to the bathroom and around their shower and also around eating. And so all these normal activities of daily living are taking a lot of extra time. And so then obviously this causes a lot of impairments in functioning, right? They're always late for school. They don't want to go out and socialize with their friends. It's causing strain within their family. And it's causing a lot of distress because they don't want to be washing their hands all these times, but they can't find any other way to get rid of that distress that they feel with their obsessive thoughts. The only way to stop the thoughts is to neutralize it with the behavior. So it's causing a lot of distress when it gets to the point that we call it full-blown obsessive compulsive disorder. So what are some examples? I had already mentioned contamination is a very common one, and that can be, worrying about germs or, objects can be contaminated with other things, like they could worry that there's blood on surfaces. A lot of times symmetry. So that might be that they have to, that they notice if anything is on one side, on the left and not on the right. And so that can become an obsessive thing. So if they see something that's uneven, they can't get their mind off of it and they will obsess about it. Unwanted sexual thoughts can become obsessions. Scrupulosity is another common obsession, which is basically a fear of sin. So wanting to be very rigid in following religious behaviors. So for example, fasting is considered a normal thing in some religions. And I had a patient who had OCD, scrupulosity type, and he was afraid to drink water when he was fasting because what if the dishwasher had failed to remove every single molecule of food off of his glass? And if he were to drink water and the water became contaminated with that molecule of food that was, not taken off completely by the dishwasher, then he would be ingesting that molecule of food and therefore he was sinning. And so it's one of these where it's a normal behavior of fasting, but it's taken to such an extreme that it's unhealthy, right? You can't not drink water for days at a time. You can't deprive your body like that. And he sort of understood that, but really was so afraid of the sin of ingesting food, even if it's accidental. So that's an example of scrupulosity. And then another common obsession is doing harm. So it could be, doing harm to other people or doing harm to themselves. Sometimes they will worry that they're going to do something to kill themselves. And unlike somebody with depression who is, no longer wanting to live, someone with OCD feels, we call it ego dystonic. So it doesn't fit with what they really want. They're not depressed. They don't want to hurt themselves, but somehow they have this fear that they're going to do something to hurt themselves. So it doesn't match with their desires, but they're yet obsessing about it and very distressed by those type of thoughts. So those are just some examples and common types of obsessions. And with compulsions, so these are what are the common behaviors that we see in obsessive compulsive disorder. So cleaning is a big one, and that can be cleaning of your hands, cleaning of the home, checking things and rechecking things. So for example, checking to make sure that the stove is off before you leave the house, right? Might be normal if you cooked and you're not sure whether you turned it off to go back and check one time. And normally someone without OCD would look and see that it's off and say, okay, and then your anxiety goes down and then you leave the house. But someone with OCD might check it, then they go to leave the house and then the anxiety pops up again and they don't have that certainty that it's actually off and then they have to go check again. And so they might have to check it a certain number of times to make sure with absolute certainty that it is off, because that first time doesn't neutralize their anxiety. Counting things can become a behavior that becomes compulsive. Repeating actions over and over again until it feels right. So there's something that they do that it won't quite neutralize their anxiety, and so they'll do it again and then they'll do it again, and somehow, somewhere in there, they've done it enough times that it just feels right, and it feels like the anxiety's been neutralized, and so they've done it enough that that it neutralizes the anxiety after repeatedly doing the same activity multiple times. Sometimes people have certain prayers that they recite, and again, normal to pray if you're feeling anxious, but this can become a compulsion when there's a certain prayer, and if they get distracted momentarily, they have to start over, or they'll say it and the anxiety's still there, and then they'll say it again and say it again, or they have a certain number of times that they have to say it until the compulsion or the obsession or the anxiety from the obsession goes away. And also ordering and rearranging can be a common compulsion. So how common is OCD in the chromosome 18 conditions? And we don't really have an answer for that at this point. Anecdotally, we think that it may be more common. We do know that anxiety disorders are more common, and OCD technically is categorized in sort of its own type, so obsessive and compulsive and related disorders. But if you've known anyone with anxiety or had OCD yourself, you know that there is a big anxiety component to it. So it seems reasonable to guess that if we're more at risk for anxiety, we're more at risk for OCD, but we don't have an answer for that yet. It's not something that we have collected data on in the mail-out surveys, where in years past I've given you information about how much anxiety we have in our population and the different syndromes, and how much depression we have, but we haven't collected the OCD data. So there's only a handful of people who have had a full in-person psychiatric evaluation to make a diagnosis, and the numbers there are so small that they don't really tell us about the frequency. But multiple people have asked to hear about OCD in years past, and that is, the reason that we decided to discuss this topic this year. So there's definitely reason to believe that people with a chromosome 18 change may be at higher risk for OCD, but this is still something that we're not clear on yet. So what causes OCD? So like everything in psychiatry, it's multifactorial. So we've got multiple different things that all increase your risk. So there's not one thing that causes it. It's a bunch of very small things, each one of them increasing your risk slightly. And when you have enough of them, then you can manifest an obsessive compulsive disorder. And so with genetics, there's no one gene. So there's numerous genes. There's not any on chromosome 18 that we know of for sure that increase the risk. But there are numerous other genes, and probably lots more that we don't know about yet, that can each add on a little bit of risk. There are areas in the brain that have some dysfunction that we see in people with OCD. There's also temperamental traits, and temperament is an example of temperament would be introversion versus extroversion. So it's kind of thought of as personality traits that we're born with. So some people are kind of more introverted, some are more extroverted, and there's no reason that caused it. It's sort of how they were born. There may be some variability over their lifetime, but generally people sort of are born one way or the other. And so people who are tend more to internalize things and be a little bit more inhibited tend to have a little bit higher risk of having a diagnosis of OCD. And then there are some environmental factors. So people who have had major traumas or abuse are at higher risk of developing OCD later. And also there's a specific type of OCD, which we won't go into detail. It could be its own talk. It's called PANDAS, which is, it's a mouthful, pediatric autoimmune neuropsychiatric disorder associated with streptococcus infection. So that big mouthful, it basically is when there's sort of an autoimmune response to a strep infection, and it manifests with sort of a sudden onset of OCD symptoms, which is not what typical OCD looks like. Typical OCD has a very slow development over time where they become a little bit more obsessive, a little bit more compulsive, and it's years in the onset, as opposed to a PANDAS type of picture, which is almost overnight that they develop these OCD symptoms. So that is an example of, kind of an environmental thing, but it's sort of a separate illness, which is treated slightly differently because we are, treating the strep infection. So that's not mostly what I'm talking about when I'm talking about OCD, but there are other environmental things that can increase risk for OCD. So one of the big questions that parents were asking is, if our kids are at risk for OCD, is there anything that we can do to prevent it? And we really don't have a good answer for a way to prevent the onset of OCD. So, we just talked about all the different factors that increase your risk, and all these things increase it slightly. So we really don't have control over the personality that we're born with. We don't really have control over a lot of things in our environment. Trauma, abuse, these things can happen without our control. The temperament or kind of personality traits you're born with aren't something that we have control over. Genetics, we are born with these things. So there's not a lot of risk factors that we can modify. However, when we have the onset of illness, we can do some things to help reduce the progression. And so one of the biggest things that helps the OCD to progress is something called family accommodation. So when a child is feeling uncertain about something, or they want their socks and their shoes to be done a certain way, and this is something that naturally happens, that parents just do out of empathy for their kid because they're distressed, they're upset. You're trying to leave for school, they're upset about the way their socks feel, they want to take them on and off 10 different times to get it to lay just right until it feels just right. Or they want the parent to help, and the parent just needs to get out the door, right? Because they're going to be late for work, the kids are going to be late for school. And so they come and they fix the sock and they get it just right, and then they go out the door. And then the kid, another example would be the kid who doesn't want to eat off the same silverware or plates as their family. And so the family wants them to eat, right? Because your kid's got to eat. And so they buy them their own set of plastic silverware because that's all they'll eat with. So those are examples of family accommodation, because we're trying to accommodate the OCD to get that distress to reduce in the moment. The problem is that over time, that actually helps the OCD to progress. And so ways that we can kind of reduce that accommodation can help to keep it from progressing, which is something that when you get your child into treatment, they will really help with working with you on reducing the accommodation that you do at home. And then also getting help early. So we know that the longer time there is between the onset of symptoms and getting treatment, the worse the longer term prognosis is. So if you're starting to see any kind of symptoms that look like OCD, don't wait for the point where they can't leave the house, they're failing out of school, the whole family is, just at each other's throats over this, before we decide to get treatment. Start getting treatment early when it's easier to treat and we have a better long-term prognosis there. So if some of these examples that I've given and things that I've talked about sounds a little bit familiar, you're a little bit worried, or maybe my kid does have OCD, what do I do next? Well, it sort of depends on how sure you are or what exactly you're suspicious about. So if a lot of times parents will say, well, that does kind of sound like my kid, they kind of do this, but do all kids do that at this age? Is that normal? And so if it's very, it's not extreme, it's not really disrupting things, you're not really sure, or if there are other physical symptoms that make it seem as if maybe there could be, a PANDAS type picture if they've had a recent strep throat or something like that, then a good first step would be pediatrician, because pediatricians are great with saying what's normal, what's not normal. And so they can help you to kind of determine, is that something that, yes, all kids at this age do, or maybe you need to go to see a therapist to get a little bit more evaluation. If some of the things that I've said just sound exactly like your child, that you're pretty sure that there's some kind of OCD or some kind of anxiety that's there, but it's pretty early, it's not really disrupting everything in life, the symptoms are mild, it's not taking them hours a day, then first step would be getting in to see a therapist or a psychologist to get working on therapy, which we'll talk about types of therapy in a minute. If the symptoms are really severe, the examples I gave earlier, they're failing out of school, they're not socializing with friends, they're missing out on milestones, then what we want to do is probably go ahead and start with getting a therapist and getting a psychiatrist, because we're going to want to do some combination medication plus therapy treatment. So the bottom line too is just get started. if you're worried about anything and you start at the wrong place, that's okay. People will refer you, but don't let it stop you if you're not sure that you're taking the exact right step. Just get started, and people will guide you as you go. So what does an OCD evaluation look like? So this can be done by a psychologist or psychiatrist. It's done mostly by clinical interview, and a lot of people ask, what does a psychiatric interview look like? What is an evaluation? And if you want to go and look at my blog, austinchildpsychiatry.com/blog, I have a whole article describing what a psychiatric evaluation looks like. So it's a clinical interview, listening to the child, listening to the parent, observation of the child, that helps us to kind of make a diagnosis. There are standardized measures that we can use. You can do neuropsychological testing, which is not required. It can be just done by clinical interview. There is a kind of a standard form that we can use called a YBOCS or a CyBOCS, CYBOCS. It just stands for Yale-Brown Obsessive Compulsive Scale, or the CyBOCS has Child Yale-Brown Obsessive Compulsive Scale, which is basically a giant inventory of all of the common OCD symptoms and kind of logging them and then tracking that through the course of the illness to see where they're what's improving and what still needs to be worked on. But generally, one appointment with a psychologist or a psychiatrist, or just a couple appointments, should get you to the point where they're able to pretty clearly make a diagnosis. So what is OCD treatment? So there's sort of three main parts. So individual work with a therapist, between the child and the therapist, and with including the parents in that process as well, is really the mainstay. So in OCD, therapy really does the heavy lifting in the treatment. Medications are really reserved, similar to depression, anxiety. They're more reserved for the more severe cases, or if the OCD is refractory to treatment. So if we've done a couple of months of therapy, we're not making any progress, or things are getting worse, then we need to add on some medications. But we wouldn't treat with just medications and no therapy. All right, so we'll talk a little bit about what therapy looks like for OCD. So if you've heard any of my talks, you've heard me talk about cognitive behavioral therapy. There's a very specific type of cognitive behavioral therapy, or CBT, that we do for OCD, and it's called exposure and response prevention. And so what that is basically is exposing the child to whatever it is that triggers their OCD symptoms. So that might be exposing them to a surface that they feel is dirty, a doorknob or something that they're afraid of the germs, and then preventing them from washing their hands. And this is something that's done in a very slow and gradual way to help them to learn that the anxiety eventually goes away, even if you don't neutralize it with your compulsion. And so that is where the name exposure and response prevention comes from. So this is sort of something that first they're going to learn calming techniques to calm the body. They're going to learn how to challenge those obsessive thoughts and fight back against the OCD, which tells them that they have to be absolutely certain about something. And so saying, there could be a germ on that doorknob, but there's no way to know for sure there's no germs. But if it does get on my hands, what's going to happen? Am I for sure going to get sick? Well, and so challenging all of those obsessive compulsive beliefs. And then once they can challenge the thoughts, the OCD thoughts, and once they've learned the calming techniques, then they would start the exposures. And exposures are done, they do exposure ladder. So they'll have the child write down all of their specific triggers, and then they rate them. This one's not that big a deal. This one's a little bit bigger deal. This one is the absolute worst one. I do not want to ever have to touch a doorknob and not wash my hands, but I think maybe I could go ahead and eat off the same silverware that my family does. And so they would try the easier one first, have some success with it, and then try the next one. And so they're working in all the time using the calming techniques, challenging their thoughts, and then they work their way up through the exposures. And when you do look for a therapist, that type of therapy is very specific. And so when you're looking for a therapist, you want to specifically say, do you have training in exposure and response prevention? For regular depression, regular anxiety, a lot of therapists say, I incorporate some CBT techniques, and then I also do some psychodynamic and, other types of therapy. But for OCD, it's very specific. We want to find somebody who does exposure and response prevention because there's the best data to say that is the most helpful type of therapy. Okay, and so OCD support by the family. So we talked a little bit about kind of reducing the accommodations that you're doing, because the accommodations, again, they're done because you want to reduce the anxiety that your child is feeling, but we're only reducing it in the moment, and we're strengthening the OCD. And so that'll be something that the therapist would work with the parents on, because in OCD, family accommodation it happens in every single family with OCD. That's the norm. And that's what the OCD just does to a family. And so it's going to be something that's going to have to be worked through in therapy. And the therapist can give guidance on how to slowly withdraw the accommodations that the family's making. And also supporting the exposures, because the exposures will have to be continued outside of the therapy office. And so there'll be things that are done at home. And so that will be something that the family is going to need to work with a child on. And then medication. So as I said, this is reserved for just severe cases of OCD, or people who have not responded to CBT, the ERP. So they've done therapy for a couple of months and haven't made progress, or they're worsening, or maybe their OCD is so bad that they can't even engage in therapy. So those would be some examples of times when we would add on medications. The mainstay for OCD is the selective serotonin reuptake inhibitors. If you've heard any of my talks, you've heard me talk about the SSRIs. This is Prozac, Zoloft, Lexapro. They're also first line for generalized anxiety and depression, and they are also effective for OCD. Clomipramine is sort of the old standby medication. It's very, very effective. It's an old medication. It's a tricyclic antidepressant. We don't use it very often. It's not as tolerable as the SSRIs. It causes weight gain, constipation, a whole bunch of different side effects. And so although it is really effective, it does cause more side effects. And so usually we start with an SSRI, because if we can get a response from something that doesn't cause side effects, that's definitely ideal. And often we end up needing to augment or add a second medication on to help the SSRI work better and to get additional benefits from the second medication. And OCD, it's more common to have to go to higher doses on a medication and add something separate. And so often antipsychotics are the medication of choice for augmentation. And it is a medication that we use in psychosis, but we also use it for mood stabilization. The name makes it sound a little bit intimidating, but actually they stabilize mood, they decrease anxiety, they help with sleep, they have a lot of different effects. They work on a different neurotransmitter, they work on dopamine, so not the same as the SSRIs, and so often we augment with those. And sometimes we also use as needed anxiety medications. Usually we would do something like Vistaril, which is a cousin of Benadryl, or hydroxyzine. Also propranolol, which is a blood pressure medication, which sometimes we use as needed at very tiny doses for anxiety. Ideally, part of the therapy process is being exposed to something that triggers your anxiety and learning to sit with it and reducing that urge to do something to get rid of it, to perform a compulsion to get rid of it. And so we don't necessarily want to use anxiety medications, because we want the child to have the experience of feeling that anxiety and learning that it goes away, and learning that we can live with anxiety. The goal is not to live with zero anxiety. The goal is to learn how to feel it and let it pass. And so not ideal to use an as-needed anxiety medicine, but for some people, that anxiety is so bad that they can't even do that first exposure on their exposure ladder, or they refuse to go into therapy. And so we can't even kind of get started unless they have something to kind of take that edge off. And then they can get in, and then they can have some experiences of success and learn, oh, okay, I can face these fears, I can conquer this, okay, and then they're able to use it without as needed medications. But that would just be in the circumstances where we don't have any other options. So that is sometimes done. And I want to tell you guys a little bit about just kind of resources. If you're feeling like your child does have OCD, first step in almost all cases is finding a therapist. When you want to find a therapist, good places to find referrals would be primary care doctor or pediatrician. They may know some therapists in the area that they can refer you to. Ask around if other kids that you know are being treated for OCD or for anxiety, getting some good recommendations for therapists. School counselors can be a really good resource of knowing who's in the community who can treat OCD. Psychologytoday.com is a good resource. You'll have to do a little legwork to screen, to call the therapist and find out if they actually treat OCD, and use the exposure response prevention type of therapy. But it can be a resource if you haven't found any other places to find a therapist. And as I said before, you definitely want to ask about what style they're using, because we really want to have somebody that's doing that exposure and response prevention. And also, when considering getting therapy, you may want to consider getting 2 therapists. This is a quote from one of my favorite authors, L.R. Nost, who writes a lot about gentle parenting. And she says, "When little people are overwhelmed by big emotions, it's our job to share our calm, not join their chaos." And, all of you have children with very complex medical needs. That is a lot of stress for any parent to carry around, even someone without depression or anxiety. And then if you take OCD on top of it, you've got 2 big stressors you're having to deal with. And that is something that I tell families, even when there is no chromosome 18 condition, it's just OCD. It's very stressful on the family. There's all the accommodations that the family has had to do, which causes a lot of anxiety. And then you're having to take it away. That's causing a lot of anxiety. The more space that you can have to absorb some of that and to tolerate that, the better the child's going to do. And so might be a helpful thing to consider getting some support for yourself. And it can help even if you don't have any depression, don't have any anxiety, you just need the support to get through this time. It's a challenging illness to work through for everybody. Couple of books that are good. Bonnie Zucker is a psychologist who wrote a book called Parenting Kids with OCD, and she talks a lot about parent accommodation and all the things that a family does that support the OCD and that help to make it better when we're kind of in the recovery process, and how we treat the OCD before they're in treatment, which partly is accommodating the OCD, and then once we're in treatment, how we change that. So great book, I would highly recommend. Talking Back to OCD by Dr. John Marsh is another good book about working with OCD. There's an International OCD Foundation, and this is their website here. And then you can also find a lot of good information on the American Academy of Child and Adolescent Psychiatry website, acap.org. And then also support groups. The International OCD Foundation has a list on their website. This is a link to that site. They have both local and wider virtual communities for support. So those are some places where you guys can go for some extra resources and extra support. And next thing, we will be doing a live Q&A. It's going to be on Tuesday, July 13th at 3:15, when I'll be answering some of your questions about OCD. I hope to see you all there. Thank you, guys.